Good morning, everyone. So today I'll be presenting about the anesthesia for hip fracture repair based on the British Journal of Anesthesia. So, introduction. First of all, hip fracture is a major concern and burden for our healthcare system, and it's projected that the number of hip fractures will double between 2017 and 2050 from 2.2 million to about 4.5 million. And hip fractures are actually the commonest reasons for elderly people to undergo surgery and the type of fracture requiring hospital admission. Timely hip fracture repair is associated with a lower morbidity and mortality, and reason for in the last few years there has been an improvement in these numbers, and this improvement has been multifactorial, but it is mainly contributed by the introduction of clinical guidelines in England and Ireland and introduction of best tariff practices for hip fracture care. There are many guidelines regarding anesthesia for hip fractures, but there are inconsistencies in the recommendation for analgesia, anesthesia, pre-op investigation, and optimization. So in this article, they actually aim to achieve a consistent guideline that focuses on enabling timely repair of hip fracture in a way that caters to the physiology of frailty in elderly. So there have been also more recent guidelines by the Association of Anaesthetists and also Fragility Fracture Network that have addressed these inconsistencies, which I have incorporated in my slides. Early mortality in hip fractures have improved in the past decade, but less is known about the morbidity and also restoring of function. And to address this, the national data collection has been started. Example, in the BPT or the best practice tariff for England specifies post-op screening for delirium using the 480 questionnaire, and the national hip fracture data collects data on proportion of patients that actually return to their home after the fracture. So some of these outcomes, it might be difficult for us to assess, but measuring them will help to improve the quality of hip fracture care in the future. So these are the main criteria that has been outlined by the English and Irish best practice tariff clinical criteria. So in England, the time to surgery is within 36 hours of presentation. And each patient has to be assessed by a geriatrician within 72 hours with a proper pre-op cognitive test using abbreviated mental test score, and should be assessed for bone protection, specialist for falls assessment, nutritional assessment, and also post-op delirium assessment, and they should be assessed by a physiotherapist on the day of or the day after the surgery. Whereas in Ireland, it's recommended that the surgery should be performed within 48 hours after admission, and they should not develop a new grade 2 or higher pressure ulcer, and also should be assessed by a bone health assessor and also specialist fall assessment. So all these criteria are mainly to, the aim is to standardize and optimize the standard of care in hip fractures. So actually this is an example of the 480 questionnaire that has been implemented in England to actually assess the patient's delirium, post-op delirium. So based on this, there are 4 questions that can be assessed, which is the alertness, and then we try to assess the patient's age, date of birth, attention, and also acute change of fluctuating cause. And a score of 4 or above actually indicates that the patient has got delirium or cognitive impairment. So moving on to the evidence-based anesthesia for hip fracture repair, there is actually no standard approach to show which is better, whether GA or regional is a better approach for hip fracture repair. But the most recent Cochrane review actually concluded that the only benefit of regional anesthesia over GA is there is a lower rate of venous thromboembolism in the absence of pharmacological thromboprophylaxis. So this is actually the Cochrane review, which actually assessed all the different outcomes, primary outcomes in relation to the different modes of anesthesia. And actually this study concluded that the only reduction when spinal is given, regional anesthesia is given, is that there is a reduction in the rate of thromboprophylaxis. So In terms of mortality, which is one of the primary outcomes that they have assessed, there is no difference in the mortality when you compare GA and also neuroaxial block. It is the same goes for pneumonia, myocardial infarction, strokes, acute confusional state. But in DVT, there is a very significant amount, there is a significant amount of reduction in the population who has undergone spinal anesthesia. However, the problem is the sample size is quite small, so it's quite difficult to actually conclude that spinal anesthesia actually reduces the risk of developing developing DVT without thromboprophylaxis. So there are variations in practice within different modes of anesthesia, and hence it is important for us to standardize the technique and outcome measures. Rather than choosing GA or regional, the aim should be to optimize the GA or regional, whichever technique that we choose to give the patient. So whether to proceed or not. So elderly patients, as we know, are associated with frailty and they have got multiple comorbidities, and sometimes this puts them at a higher risk. So some of them may even be told that they are not a good fit for an elective hip surgery. But the risk of proceeding must always be weighed against the risk of a non-operative approach. So this is an article that was that shows that where they try to understand the mortality rates based on using the ASA physical status based on the National Hip Fracture Database, and based on this study, up to 1/3 of patients actually die in a year after hip fracture. And when they analyze against the ASA physical status, the rate of death in hospital for ASA 1 to ASA 2 patients are actually very low, about 1.8%, compared with ASA 4 patients, which is about 16.5%. And the survival rates for ASA 4 patients on first 3 pre-op days is actually pretty high. So it's 98.8%, 99.1%, and also 99.1% in the first 3 pre-op post-op days. And post-op day 6 survival was also actually quite high, which is 99.4%. And nearly half of the 1,427 patients who did not have surgery died in hospital. So instead of giving the family or the patient a very pessimistic explanation, we can actually explain to the family and the patient that over 98% of ASA 4 patients can actually survive both day of surgery and day after it. Okay, so when should the fracture be fixed? So based on the English best practice tariff and also the Scottish hip fracture audit standards, it states that the hip fracture should be repaired within 36 hours of admission, whereas the Irish hip fracture database suggests within 48 hours. So although these targets seem achievable and optimistic, we should try to actually get it done even sooner. So Sayers and colleagues actually demonstrated a 9.4% increase in 30-day mortality risk when hip fracture repair is performed more than 24 hours after hospital admission. And among patients with mild to moderate cognitive impairment, delaying surgery for more than a day can actually increase the risk of delirium twofold. Hence, it is important for us to try to perform the surgery as soon as possible. So the hip attack study, which was actually an international randomized control trial, where studied a large multi-center international RCT. I think even Malaysia actually took part in this study. It compares complication rates when accelerated hip fracture is undertaken. Accelerated here means that within 6 hours of diagnosis versus standard care, which is within 24 hours. However, based on this study, there is not much of a difference when it compares the mortality risk. But then, the risk of delirium and time to mobilization and discharge were all significantly lower in the accelerated group. So actually, in this diagram, I am trying to show that the p-value in terms of death and composite major complications is actually insignificant when you compare the accelerated surgery group and also the standard care group. Whereas in terms of delirium, reduction of delirium, the group which has undergone an accelerated surgery within 6 hours has a significant reduction in delirium. So moving on to hypotension. So based on the ASAP-2 study, there was actually a statistically significant increase in 5 and 30-day mortality in those with decreased MAP. So one of the most important cause of cardiovascular and respiratory collapse and hypotension is actually bone cement implantation syndrome. And this involves mostly during cemented hemiarthroplasty, total hip replacements, and any procedures involving instrumentation of the femoral canal. The risk factors that predispose a patient to developing BCIS includes meal, diuretic usage, increasing age, and if the patient has got any significant cardiopulmonary disease. So how do we reduce the risk of developing BCIS? So one would be conduct of the surgery and the next would be conduct of anesthesia. So when you talk about the conduct of surgery, the surgeon should communicate with the anesthetist and to inform the anesthetist that they are about to prepare the femoral canal for cement and prosthesis insertion. The surgeon should prepare, wash and dry the femoral canal, and the use of pressurized lavage system is recommended to clean the endosteal bone of fat and marrow contents. A distal suction catheter should be used on top of an intramedullary plug, and cement should be inserted from a gun in retrograde fashion on top of plug, and catheter should be pulled out as soon as it is blocked with cement. And the surgeon should ensure that he or she does not use excessive manual pressurization or pressurization devices in patients, especially those at higher risk of developing cardiovascular events. On the anesthetic side, the anesthetist should ensure that the patient is adequately hydrated before and also during anesthesia. Should be extra vigilant once the femoral head is already removed and surgeon has already indicated their wish to instrument the femoral canal. Good communication with the surgeon that the anesthetist is aware that the preparation of the canal is going to occur. We should aim to maintain the systolic blood pressure within 20% of pre-induction values throughout the surgeries, whether using fluids or vasopressors. Intra-arterial BP monitoring for those that we think that is at a higher risk of developing bone cement implantation syndrome, and uncemented prosthesis should be considered for high-risk patients. Okay, moving on to the use of peripheral nerve blocks. So fascia iliaca compartment blocks, femoral nerve blocks, and 3-in-1 blocks provide effective but incomplete analgesia in patients with hip fracture. The reason being that it is innervated by both lumbar and also sacral plexus. Hence, it is important to perform multimodal analgesia strategies. The lateral femoral cutaneous nerve should also be blocked as it supplies the skin that is incised. Additional local anesthetic infiltration may be required if a posterior surgical approach is used. Example in a total hip replacement. So the Association of Anaesthetists recommend in their latest guideline, which was in 2020, for a single short nerve block to be provided as soon as the patient arrives in the emergency department, and it can actually be repeated after 6 hours for adequate pain relief and also to reduce quadriceps muscle spasm and positioning for anesthesia. Avoiding cognitive complications is an important part in hip fracture anesthesia. So delirium actually affects about 25% of people with hip fractures, and it is associated with increased rate of adverse outcomes, including mortality and need for nursing home. So timely hip fractures actually will help to reduce the risk of delirium. And certain drugs, example opioids or drugs with anticholinergic activities such as cyclizine, atropine, chlorperazine should be avoided. in patients that we think at a risk of developing cognitive complications. So actually, this is a study performed by Chuan Zhao, and actually shows that they have divided the patients into two groups, which is a care bundle group and also a control group. So the care bundle group actually were given a fascia iliaca block, and then analgesia was rationalized, and they were drugs that triggered delirium were avoided with regular education program for their staff. And this was compared to a control group. And in the care bundle group, it is actually shown that there is a significant reduction in the risk of developing delirium at day 3 as compared to the control group. Okay, so there are a lot of controversies when it comes to hip fracture anesthesia. So number one would be delaying or delay versus optimization. So as we know from the previous slides, we realized that timely repair of hip fracture is very vital, as number one, it provides analgesia and is also associated with lower mortality and also complications. But there may be situations in which the reason for the delay is more important than the delay itself. So delaying the surgery may be appropriate if we can actually perform the optimization during the short period of time within the 24 hours. But in order to achieve this, we need a effective orthogeriatric team and good resources, which may be rather difficult to achieve in certain settings. So despite the multiple comorbidities in patients with hip fractures, there is often not much that can be effectively optimized while the patient remains in pain and immobile. So whatever that we can optimize should be addressed promptly. But whatever it is, we should try to minimize the delay, and it should be a multidisciplinary decision whether to delay, about the decision whether to delay. Anemia and blood transfusion. So pre-existing anemia is relatively common in elderly patients, and this can be compounded by the effect of acute blood loss from the fracture itself or during surgery. And anemia can provoke organ ischemia and also delay functional recovery in frail patients. But transfusion itself has its own risk. So there have been actually multiple studies to assess the association between hemoglobin concentration and outcome in patients with hip fractures. However, the most recent Cochrane review, this was in 2016, which shows there's no clear benefit to either restrictive, meaning you're targeting a HB of more than 10, or a liberal concept where you're targeting more than 8 transfusion thresholds, apart from very low quality evidence of lower risk of MI in the liberal group. However, the Association of Anaesthetists states that HB target of more than 9 should be adopted for frailer patients, and this target should be actually increased to 10 for those with ischemic heart disease or those with symptoms suggestive of anemia. So what are the strategies that can be done to reduce blood loss? Number one would be expediting the surgery, minimizing operative time, and use of tranexamic acid. So tranexamic acid actually is not very well documented, but from what I've gone through, the tranexamic acid reduces the transfusion requirements, but there has been uncertainty about the risk of thrombotic events. And future research is actually needed. So it is actually suggested for tranexamic acid to be used in patients who are at high risk of bleeding and with complications of anemia. Moving on to undiagnosed cardiac murmurs, some patients may present with a cardiac murmur which is not known to the patient or to the family or been diagnosed previously. Sometimes they can't actually tell you about symptoms as well. So in these cases, a pre-op echocardiogram may be beneficial and can influence anesthetic management, provided the surgery is not delayed while awaiting for the result of the echocardiogram. But anesthesia should proceed with invasive blood pressure monitoring and to ensure there's proper cardiovascular stability during the surgery if we cannot obtain the echocardiogram results immediately. The use of antiplatelets, anticoagulants, and spinal anesthesia. Approximately 30 to 40% of people with hip fractures in the UK are on some form of antiplatelets or anticoagulants. So over here, the role of the anesthetist is to balance the four main risks of these medications to the perioperative care. So these are the surgical bleeding and vertebral canal hematoma versus the abrupt cessation of medication and delay of surgery. So the incidence of vertebral canal hematoma in the UK is actually very small. It's 1 in 118,000. And the extent to which this small risk of vertebral canal hematoma is increased in patients with hip fracture is unquantifiable, but actually is most likely very small risk. The Association of Anesthesia guideline, on the other hand, adopts a more pragmatic approach to anticoagulation when spinal anesthesia is deemed superior to GA, example in a patient with severe chest disease. So number one would be if in a patient with only on a single antiplatelet, example even clopidogrel, it is not a contraindication to spinal anesthesia. Spinal anesthesia may be appropriate for patients taking dual antiplatelet therapy who are unsuitable for GA. Again, we have to measure the risk and benefit. For patients taking warfarin, spinal anesthesia can be performed once the INR is less than 1.5. And if the INR is more than 1.5, the patient should receive an initial dose of vitamin K upon presentation in ED. And with further vitamin K or prothrombin complex concentrate given if the INR remains more than 1.5 after 4 to 6 hours after the first initial dose of vitamin K. Regarding the need for bridging therapy, it is not required for patients with uncomplicated atrial fibrillation or previous venous thromboembolism, but it may be required for those with more complex cases, example, if patients with metallic valves. Direct oral anticoagulant activities, this is also becoming more popular. So, example would be thrombin inhibitors or factor 10A inhibitors. So, in these drugs, we don't commonly assess by standard coagulation tests. So, but most of the time, unless the patient has got severe renal dysfunction with a creatinine clearance of less than 30, the pharmacokinetics are pretty predictable. And spinal anesthesia can actually be provided after 2 half-lives have elapsed, usually within a day after stopping after the last dose of the drug has been taken. Okay. So moving on to the conduct of spinal anesthesia, the ASAP adopted a standard dose of bupivacaine of 10 milligrams for use in spinal anesthesia, and it's stated that intrathecal opioid should be limited to only fentanyl. However, when they have went back retrospectively, when they investigated, they noticed that the median dose of 2.5 mils of bupivacaine, 0.5%, which is about 12.5 milligrams were used, and 50% of these patients received intrathecal diamorphine. So the reason being the higher dose is given most of the time is because we are worried that the duration of the spinal anesthesia may not be sufficient for the proposed surgery when you give such a low dose. That's why most of them have been given a higher dose. However, there's been studies done by Ben David and colleagues also in the UK, which compared bupivacaine 4 milligrams plus fentanyl 20 micrograms diluted with saline to a total volume of 2 mils, which was described as mini dose, and comparing with those we given 2 mils pure bupivacaine or 10 milligram without opioid. It shows that the patients that were given mini dose, actually there was not much of a difference. Both of them had sufficient analgesia and anesthesia for up to 110 minutes. And in the mini dose group, they actually required lesser intervention for hypotension. So actually this suggests that lower dose is more desirable as compared to a higher dose, especially when we give it together with a fascia iliaca block. So whatever it is, with the anesthetic team should hold a discussion with the surgeons prior to the op to discuss how long will the surgery take, whether the surgery will require a reduction before the surgery, and also we should cater for the positioning as well. So if surgery becomes unexpectedly prolonged, it is not wrong to give additional LA, systemic analgesic administration, and even conversion to GA is an acceptable strategy. So do we need to give sedation in all cases that patients go through spinal? So according to ASAP, sedative drugs were actually given to 75% of patients who underwent spinal anesthesia. This includes benzodiazepine, propofol, ketamine, all has been given. But the problem with sedative and analgesic medications is very clearly documented that is related to post-op delirium. Comfortable positioning actually can be achieved with the use of peripheral nerve block, and most patients actually fall asleep once anesthesia has been established. So sedative drugs can be avoided, but even if it is really needed, we should limit it to short-acting titrable agents such as target control infusion of propofol. Moving on to the conduct of a general anesthesia, the main aims would be to avoid hypotension, avoiding delirium drugs, and providing lower anesthetic dose, which is catered to the physiological reserve of the patients. How to optimize the anesthetic dose? Number one would be to perform depth of anesthesia monitoring. If an inhalational agent is used, age-adjusted MAC, careful titration of induction agents against clinical and EEG-based assessments of anesthetic depth, and of course, the use of peripheral nerve blocks to minimize the required dose of anesthetic agents and opioids will also help to optimize the anesthetic dose. We should also maintain spontaneous respiration during general anesthesia to actually minimize the risk of atelectasis, barotrauma, and hypotension, which is actually associated with positive pressure ventilation. Whether to intubate or to use a supraglottic airway, there have been concerns that in elderly patients, trauma, they are at a higher risk of developing aspiration. And another thing would be the position during surgery, limiting our access to airways due to positioning. However, I think we can actually achieve spontaneous respiration and deep anesthesia using higher deep inhalational induction or topical anesthesia to avoid muscle relaxant if possible. And if intubation is deemed to be not required, you can always use a second generation supraglottic airway that can provide additional protection against aspiration. Moving on to post-op recovery, post-op critical care should be considered, but is by case-to-case basis after risk assessment and after discussion with the multidisciplinary teams. It is not a must that a patient has to, all patients with hip fracture has to go to a critical care unit. The most important thing would be to provide a structured post-operative management to aim for early remobilization, rehab, and maintenance of patients' pre-operative cognitive function. So the important thing would be to get all the teams involved, including the orthogeriatricians, the occupational therapists, and also physiotherapists. And post-op screening for delirium, as I mentioned earlier, is also important to actually facilitate and pick up early cognitive issues. Consent and also hip fracture anesthesia. So consent can be quite challenging because some of the patients may come in with a cognitive impairment to begin with fluctuating mental capacity. So it is important for us to involve family members or advocates early in the consent process. And it's always important for us to establish how much the patient wishes to know at an early point of discussion, because at times the patient may find it too heavy to accept whatever we are explaining. So any discussion of risk should be individualized to the patient. So risk stratification tools such as the Nottingham Hip Fracture Score may be useful, including by providing a basis of reassurance. So actually, I have also put in the Nottingham Hip Fracture Score, and this will help to actually show the predicted value for 30-day mortality. So not all patients are the same. Is the mortality rate is not the same in each patient, so should always explain to the family that everything is individualized. Patients should be offered options, whether it's spinal versus general anesthesia, peripheral nerve blocks, and sedation. Patients have the right to choose, but the anesthetist can always explain or suggest what technique is commonly performed and what are the benefits that this method can provide. And patients' experience of hip fractures has actually been studied, and the research actually suggests that what's more disturbing to patients is the post-op complications, the delirium, the pain, rather than the mode of anesthesia itself. So in conclusion, actually the outcomes have actually improved tremendously in the recent years, but the problem is that hip fractures will increase, and it is a huge concern for our public health. And timely hip fracture repair is vital and is associated with a lower morbidity and mortality. And there's very little evidence to show which mode of anesthesia is superior. 25% of patients experience post-op delirium, and this risk can be reduced with timely hip fracture, and hypotension is associated with an increased risk of mortality, and it can be avoided by minimizing the dose of anesthetic agent, whether it is spinal or GA. Okay, these are my references. Thank you.